which is being web streamed to us. We thought we should begin by getting together for a photograph. And the best place... Everyone, my name is Dr. Krishna Moorthy, and on behalf of Neurokrish and TRIMED, two organizations, I'm very pleased to welcome you to this symposium. It's the initiative of Professor Neil Dewhurst, who's the current president of the Royal College of Physicians of Edinburgh, who is a very far-thinking and a very interactive person, and who's been in India. He's been with us last year, and he was the one who wrote to me and said, would you like to web stream some symposia to doctors in your country, because we are doing these symposia at the Royal College. And we said we would make an effort. We did a small pilot in VHS a few weeks ago, and I believe it was quite successful. We were able to receive the web streaming, and we were able to listen to all the talks in the Royal College. And therefore, when this festival symposium came up, and you're seeing what is going on there, we said that we take the opportunity to try and bring it to as many of our colleagues as who are interested and as possible. So, and we've had a very nice response from a number of people wanting to come. I'm very happy to welcome all of you who are here, and I'm sure more people will join us as we go along. I'm going to request two people to say a few words, because the symposium starts at 3 o'clock Indian time. First, Dr. Rama, a few words about TRIMED, which is a new integrative medicine concept, which we'd like to just explain to you. And then Professor Rajan, who is a fellow of the Royal College and who has been instrumental in being our faculty advisor, advising us on a number of areas. So, Dr. Rama.
So, good afternoon, everybody. Once again, I extend a warm welcome on behalf of Neurokrish and TRIMED. A few words about what we do at TRIMED. I think many of you have already attended our programs which we held in the second part of this year. And ours is an integrative healthcare chain, and we have 4 centers with a hub. It's a hub and a spoke model. So we have the central, which is called TRIMED Central, that is in Tenampet. And we have 4 therapy centers, as they are called. So we see patients at central. We do a very comprehensive assessment, and we have this multidisciplinary team, as we call it. And the clinical processes are supervised by me, because I'm the clinical director. And we have Dr. Krishna Moorthy, who's the chairman. He has his office over there. So when the patients come in, we do this assessment, which is done very comprehensively by our team, which has an Ayurveda physician, a naturopathy physician, the physical therapist, the psychologist, and then we have our lab tests also done there, including the EEG and other tests. And based on this assessment, we put together a treatment program which actually combines the best of modern allopathic medicine with ancient medicine. So we have Ayurveda, like I said, we have the physicians, so we have Ayurveda, we have naturopathy, and in naturopathy we have several therapies. We have hydrotherapy, we have mud therapy, and then we have the yoga therapies, acupuncture, acupressure. I think you name it, we have all of them. And as you can see, they are all external therapies. So you have a combination of the allopathic medication plus the external therapies from the other ancient medical streams. So we call these verticals, where we have the Ayurveda, etc., like I explained. So we combine the treatments to give a very customized kind of treatment program for the patients based on this assessment. And usually the patients fall into 4 broad categories of pain, disability, stress, and lifestyle disorders. So most of them fall into this, other than patients with cancer, etc. But then there are certain domains where we could treat, that there are possibilities in the field that we are working in. And we get patients right across the lifespan. So we have young children, and then we have the elderly. As you know, there's a lot of neurological problems which happen. There's right from dementia. We've done very well with a 92-year-old patient with dementia who came to us, who came to the Anna Nagar Center. So the centers are placed in Anna Nagar, Tirvanmayur, Velacheri, and Tenampet. So these are our 4 spoke centers. And I'd very much like to tell you about this patient who did very well with 14 days of cognitive behavioral therapy with Ayurveda, with acupressure, physiotherapy, and all of that. So the outcome was excellent. And when we actually took on the patient, we told them that we have to just see how the patient does as the treatment program goes on. it's difficult to give a guarantee based on the age. But at the end of the 2 weeks, all the behavioral symptoms had gone because he had a lot of behavioral problems with dementia, which the family had a lot of problems handling. And because the caregivers themselves are 65 and 70 years old. So after this treatment, I think now they know how to cope with this patient, and he's been reviewing. The medication, of course, is there. It is not that we mix the allopathic medication with the Ayurveda medication or anything like that, or Siddha or anything like that. They are absolutely external therapies along with the allopathic medication. There's supervision by the allopathic physicians, and there's supervision on a day-to-day basis and documentation by the other physicians. So this is very well done, and there is a lot of process going on, which is actually evolving and getting better and better. And so across the age span, like I said, there are various programs that we could use and which you could think about when you have your patients, and people who would definitely, I think, improve with our kind of therapy along with your medication. So thank you very much for coming. Once again, a warm welcome. And I'll request Professor S.K. Rajan to share a few words with us.
Good evening to all of you. I sincerely thank Dr. E.S. Krishna Moorthy for giving me this opportunity. As rightly pointed by Dr. Rama, Dr. E.S. Krishna Moorthy has invented this particular branch of alternative medicine. Though it is existing for over 10,000 years, this Ayurvedic system of medicine. In fact, if you trace the Ayurvedic system and allopathic, most of the things we have derived only from the Ayurvedic medicine, and it has been patented in various kind of things. That is the reason why I always insist this alternative medicine should be always complementary. They are not competitive. Say, for example, a person all the time carrying on, he has a lot of problem in the stomach and the shoulder and the back and the head, this and that. And doctors are become totally confused because the fellow comes and insists, I need MRI brain, I need a CT scan chest, I need a CT this and that. Such kind of people, it's okay, we can diagnose, we can do all kind of tests, and then if you find everything is normally is not going to be convinced, we can submit them definitely for alternative therapy. They will take it for yoga, meditation, and other therapy. That when they are subjected to alternative medicine, it is very incredible. They are able to forget everything. They are given very good ambience, very good kind of mental, peace, and naturally they forget their problems like hypochondriac symptoms, something like that. So I personally feel all the institutions should have alternative medicine department. Even yesterday I was in the inaugural function of the National Pulmonologist Conference in the Chennai Trade Center for 3 days. Today also it's going on, tomorrow also it's going on. Our health secretary spoke about the importance of alternative medicine. So most of you have come here, around 3,000 doctors here. You better treat the chemical molecules to the patients suffering from chest disease. Same time not forgetting about alternative medicine. I think it will be very supportive. It's high time. We are having a lot of challenges. It cannot be completely controlled only with these chemical molecules. You also think about this alternative medicine. I was extremely happy to listen to this speak only from the highest bureaucrat authority for the government of Tamil Nadu. He spoke about this yesterday. So I am very happy. Professor E.S. Krishna Moorthy has initiated this. Those were the days when we were students. We had professors with the Royal College degree and all. They never think about this, imparting the message and sharing their knowledge, expertise and experiences, and the making empowerment of the junior colleagues. But they are doing great job. I am so proud to be associated with this institution, and we started TRIMED over there, and then VHS doing wonderful job. E.S. Krishna Moorthy has got a network all over the world. He knows most of the even Nobel laureates. He used to invite them, and frequently, not less than 4 or 5 times, he invites international faculty, and the way they impart the message is something incredible. We cannot go and read. They impart their experience. So such kind of service is something very great. All of you must imbibe. So one need not necessarily be born as intelligent. It could be imbibed. In fact, I would say I imbibed a lot of things from the genius. That is why I have written biography of Dr. Trivangadam, Dr. Athanuri Subramanian. Though I had no opportunity to move with them, I did a research work and I imbibed and listened to many people worked under them. And if you go through that, the knowledge is something very, very amazing. They had intuition, experience, and one part of time it becomes intuition. So therefore, I take this consider as a great privilege, and once again thank Magesh and TRIMED Center. I wish you all the best for the wonderful interaction you are going to listen from Royal College, Edinburgh. Thank you.
One of our chair and organising committee earlier this morning, I have felt for the last few days like a midwife, and the child is now crowned and about to be fully delivered, and my only role is to prevent episodes of anoxia, and I'm sure that won't happen either. Really quite interesting programme, and I think interesting though the speakers will be, the even more interesting bits is the interaction between audience and speakers, so I do encourage you to participate. Our first session is what's new in, so telling you a few things around 4 different specialties. I'm delighted to see we have at least 2 of our speakers with us so far. I look forward to the other 2 coming in shortly. Jane, it's a pleasure to welcome you. Jane has been a rheumatologist in Fife for nearly 17 years, is a founder member of Council of Scottish Society of Rheumatology, is closely involved with the guidelines for osteoporosis, and Jane, you're going to tell us what we need to know about rheumatology in the next 25 minutes. 20 minutes.
Thank you very much, John, and thank you for the invite to speak today. So I'm going to do a quick whistle-stop tour through some of the topics in rheumatology that are evolving at the moment. A little bit on gout, management of acute and chronic gout, a little bit on rheumatoid arthritis and how we now treat to target with the aim of complete remission. And then hopefully, if we have time, and I speak fast enough, a little bit on osteoporosis made easy. So why talk about gout? Well, gout's now the commonest inflammatory arthritis in men in the Western world, and anybody who works in acute medicine will know that it's increasingly common on the acute wards and coming into the medical admissions unit. It's increasingly common in the elderly because we're living longer with more comorbidities, more medications that may induce gout, and of course there's an obesity epidemic. Gout's important because not only is it exquisitely painful, it's the most painful acute arthritis that you can get, acute gout, but it's associated with increased morbidity, disability, poorer quality of life, which is a shame because, in fact, it's not only readily manageable in most patients, but it can be curable. But despite that, we know that it's often, and there are numerous guidelines, particularly in the last few years, with the latest one coming out this year. So, acute gout. The kind of patients that most people see are those who come in with a red, hot, intensely painful, swollen joint that looks like sepsis, but may not be. And the absolute essential feature is to aspirate the joint and demonstrate the negatively birefringent crystals that you see on polarizing light microscopy. And this needs to be as urgent as aspirating to look for bugs that may be in there, look for the crystals, phone the lab. Because if you can demonstrate that those crystals are there, either gout or quite often nowadays pseudogout, of course, then you can prevent that patient being admitted for what may be quite a prolonged stay, getting intravenous antibiotics on the assumption that it could be sepsis. So the key thing up front, just as you would within the first hour try to aspirate, look for sepsis, you need to look for crystals to save that patient a lot of pain and a prolonged length of stay. In the less acute situation, of course, you can often diagnose gout by the typical X-ray features, or you're faced with a patient with multiple tophi, or they present with typical podagra, that's acute gout of the great toe MTP joint. And these people tend to have a rapid response to colchicine. But having ascertained that you're faced with a patient with gout and not with a septic joint, what should you be doing to try and shorten the pathway in hospital or at home for these patients? Remember, this is the most painful thing you can think of in terms of your joints. Patients won't be able to walk if it's in their lower limbs, or they won't be able to care for themselves if it's in their upper limbs and they're elderly. Aspirate and inject steroids. People often think, well, oh gosh, there could be sepsis there, don't inject steroids. Very rapid response to treatment, and you can get a patient out really very often in a day or two if you do this. I will start low-dose colchicine. We used to be told that you gave colchicine every 2 hours until the patient got diarrhea, which of course meant that every patient got diarrhea. But now we use low-dose colchicine, 500 micrograms twice a day, maybe up to 4 times a day. In the elderly, they can be a problem because they tend to have less ability to tolerate colchicine. So I might just start once a day initially. Once I see that they can tolerate it, I'll build it up to twice a day or maybe 3 times a day. However, we're always taught, right, full dose anti-inflammatory is really good treatment for gout. And it is if you've got a young person, fit and well, no comorbidities. But you can guarantee from my point of view that I'm always asked to see somebody at 4 o'clock on a Friday afternoon. And they're older and they've got a little bit of renal impairment. And you're asked, should these people go on to anti-inflammatories? Well, you can guarantee that if you put them onto anti-inflammatories, come Monday morning, you're faced with acute kidney injury. So I try and avoid full-dose anti-inflammatories in anybody but the young and fit, particularly the elderly, because you're going to run into trouble. One thing not to forget, though, is that acute gout responds very well to steroids. It's that the pain and the swelling, the redness, is due to the release of cytokines from macrophage activation. So anything that inhibits that in the immune system is going to work well, and of course steroids will do just that. So in patients where maybe they can't tolerate colchicine, they can't take anti-inflammatories, don't forget you can give them oral or intramuscular steroids and they'll settle very readily. So that's acute gout. But what often happens is the acute episode is over and nothing much more is thought about it. But long-term management of gout is where the new guidelines really take effect. We know that uric acid crystallizes out of solution at serum levels of greater than 0.36 millimoles per litre. So the European guidelines recommend that in the long-term management of gout, you should aim for a serum level of less than that. But we know that it takes a lower level of 0.3 to get tophi to dissolve. So the British guidelines actually recommend a target level of less than 0.3. And if you can get a patient's serum urate to less than 0.3 continuously, their tophus load will dissolve. With that, you know that you're going to prevent long-term disability, damage to joints, acute recurrent flares of gout, and however, we know from numerous studies of cohorts of patients with gout that despite these guidelines, the average dose of allopurinol is very low, less than 200 milligrams. There's only about 25 to 30% of patients achieving target levels. So why is that important? Well, what you see clinically is just the tip of the iceberg. If you use dual energy CT scanning to look for tophi, you'll see what's obviously clinically you'd be able to palpate or see great big tophi here and round the hands. But what you don't appreciate clinically is the amount of uric acid that's laid down in the peri-joint, round the joints, tendons, the soft tissues, in the joints that you don't think might be involved. And particularly around the midfoot, which is often a site of acute gout, around the lateral malleolus. This is what you don't see, and this is what you're trying to get rid of with appropriate treatment. So we thought, we're pretty keen on aggressive management. We thought we'd look at how well we were doing in Fife. and found, unfortunately, that even in a unit that's pretty active at really focusing on target levels, we only reached 42% for less than 0.3, 63% for less than 0.36. But what we did show is that it's dependent on your dose of allopurinol. So the higher the dose, the more likely to have achieved target. So I'd like to thank the student who worked with us in the summer and my colleague Dr. Harris for this slide, which shows the predicted probability of reaching target of 0.3 versus the allopurinol dose from 0 to 600 milligrams. And you can see that if you get your patients up to 600 milligrams, you've pretty much got a 90% chance of reaching target level of less than 0.3 with associated dissolution of tophi and uric acid deposition. So, how do we do it? Okay, colchicine for 6 to 12 months. I think a lot of people are very anxious. They don't think that you can treat for so long. It's a really good long-term treatment while you initiate other uric acid treatments, xanthine oxidase inhibitors. And you start with allopurinol, yes, at a low dose of 100 milligrams, increase it to 300 milligrams, titrate it up to 600 milligrams, watching what happens to your serum urate. Don't be scared in the young person with no other comorbidities to go to 900 milligrams. But you can reduce those in the frail elderly or renal impairment. So I think this is somewhere where we really need to be focusing on pushing up the doses that we use. But even then, some patients don't respond. And there's now a new very potent xanthine oxidase inhibitor called febuxostat, which you can use second line and is very effective at reducing serum urate levels. For a few patients, there's a pegylated uricase being the enzyme that breaks down uric acid, something that great apes, birds, humans lost in evolution. And in severe cases where you need to get rid of a lot of tophi, it can be used, but it has a tendency to develop allergic reactions. So what other measures? Well, you can try and persuade them to lose weight. Don't have much success with that. You can try and persuade them to improve their diet, increase their vitamin C intake, stop the diuretics if possible, particularly thiazide diuretics. Then if they're hypertensive, you can think about swapping your candesartan or telmisartan to losartan, which is uric as uric, as are the calcium channel blockers. So when you're faced with a patient, maybe you can't quite get the allopurinol up as much as possible, you can look at what you're doing for their hypertension, because of course gout is so often associated with the metabolic syndrome. Cherry juice. Now, patients love you to recommend some med. Cherry juice is anti-inflammatory. It's as potent an anti-inflammatory as ibuprofen. But even better, it blocks tubular reabsorption of uric acid and it inhibits xanthine oxidase. So what I do now is I do everything else. I build up the allopurinol and I recommend that my patients take concentrated cherry juice, or in season, get a bowl of cherries into you every day. Okay, so that was a quick run through what to do with gout, and I hope that's given you a few pointers of how to manage that difficult disease for the patient. And it's all about treating to target for uric acid, and it's also about treating to target for rheumatoid arthritis, and I'm going to explain what I mean about that shortly. I'm going to talk about new classification criteria, treating to target, and how we now use ultrasound to make sure that our patients are in absolute remission. Now, I'm sure all of you are very familiar with patients with long-standing rheumatoid arthritis. And indeed, the classification criteria developed previously, which we used to use, was based on patients with established disease. In order to diagnose or classify a patient as definitely having rheumatoid arthritis, you needed to have nodules, you needed to have erosions, they needed to have symmetrical disease. These are all features of late disease. And it's not helpful when you're looking for patients with early disease. Why is that important? It's important because we now recognize that there's a therapeutic window of opportunity of about 12 weeks from symptom onset, that's the first swollen joint, to aggressive treatment to get the disease under control. And that 12 weeks is a time where the immune system seems to still be quite plastic, that it hasn't developed the chronicity and the pathways that mean it's so difficult to treat later on. So if you can treat your patients in the first 12 weeks and really put a lid on the inflammatory process and the immune activation, then you can change your patients' lives completely. So new classification criteria really concentrate on trying to pick up those patients who may have very early disease and who may be starting with rheumatoid arthritis. So you'd be pleased to know I'm not going to go through all this in detail. But I just want you to imagine that you're faced with either a patient in the clinic you're seeing for some other reason or in your general practice surgery. And they've maybe just got one swollen joint. And it's been going on for at least 6 weeks. And they've got an abnormal CRP, slightly raised CRP or ESR. They've already got 4 criteria that may suggest that this patient is going to go on and develop rheumatoid arthritis, because you only then need to get a low positive rheumatoid factor or anti-CCP antibody, and you've got a definite diagnosis. So what I want to recommend everybody who's not a rheumatologist and having these people referred into you is recognize just one small joint may be your patient with rheumatoid arthritis, and it's urgent that they get to see a rheumatologist so that we can treat them within the 12-week target. So any patient, even just a little joint like this for which there's no obvious cause, such as osteoarthritis, they've got loads of Heberdin's nodes for instance, or they haven't had some kind of trauma, consider, could this be a patient who's going to have rheumatoid arthritis? And if I get that patient treated early, I can change their lives. Or perhaps they're complaining of new onset of tenderness, reduced function, early morning stiffness. Again, have a look. This disease-modifying drugs within 12 weeks, and that's typically methotrexate, sulfasalazine, hydroxychloroquine. Steroids to dampen down the immune system very rapidly, because it's the only thing that works fast. Our combination treatment's going to take us 12 weeks for it to work, so we need to get steroids into them to stop that immune process. And we treat to target. I think this is a new concept for rheumatologists, that we need to see patients a lot early and escalate drug therapy to maintain remission. And you can do remission according to various scoring systems, or you can do it according to ultrasound. And more we're using ultrasound to look for active disease. Up on the very top here, you have a grayscale of a proximal phalanx with a middle phalanx, and you can't see particularly any inflammation. Put power Doppler on, which will detect movement in movement of red cells in synovitis, and you see a little bit of inflammation just sitting there in the joint. We know that ultrasound is about 7 times more effective than clinical examination in detecting active disease. Here again is a grayscale ultrasound scan of a metacarpal head. This is the metacarpal head with an erosion. This is a patient with very well-established disease who I was trying to determine whether she needed to have biologic drugs or not. This is the proximal phalanx here, again with an erosion, and the joint line. Okay, so not a huge amount to see. This girl had a slightly tender joint, but I couldn't detect any clinical swelling. Put power Doppler on, and you see clearly that there's, when my pointer comes back, you can see clearly that there's active inflammation sitting within this joint, and even a little bit sitting right within the erosion, implying that this person will continue to erode and continue to accrue disability unless I up my medication. So we now treat to remission. That is our target. Only by having patients in complete remission, and preferably ultrasound remission, can we ensure that joints will remain normal, the patient will remain in work, and they won't get joints that look like these, or the windswept knees of long-standing rheumatoid arthritis. Okay, so in the last about 3.5 minutes, we're going to have a whistle-stop tour of osteoporosis made easy. Osteoporosis is not about managing bone density, it's about preventing fractures, particularly in the elderly. And we all know that there's numerous patients who may be at very high risk, or at least high risk, of having a fracture. The problem for all of us is we're dead short of time. You're having to battle whatever the patient has come in to see you with, along with having to think about, does this patient need a DEXA scan? Do they need treatment? How on earth am I going to assess this patient for their risk of fracture? Okay, there are now online risk assessments, just as you might use the ASSIGN score for determining whether you need to treat their cholesterol. You can now assess somebody's 10-year probability of having either a major osteoporotic fracture or a hip fracture over the next 10 years. I just have them sitting on my desktop, and I'm hoping this works. So FRAX, this was developed by John Canis from Sheffield for the WHO, and you can click on whatever country you're in, put in somebody's, maybe we'll just put 64, female, and they've got a parent who fractured a hip. And then you just ask it to calculate. Oh, sorry, I have to do a little bit. And height, 165. You don't need to have the bone density. What you end up with is a predictor of what that patient's likelihood of getting a fracture in the neck is. So what we say is if that likelihood is 10% or more for any major osteoporotic fracture, send them for a DEXA scan. Let's find out what it is that their bone density is, and try and actually determine whether they need treatment or not. The other one is Q fracture, and for the sake of time, I'm not going to go through that. They have their advantages. FRAX, you can put in the bone density. Q fracture, you can include falls, for instance. And they're also available as apps, which is very helpful if you're on the move and thinking about that patient. So, when to refer or treat? Refer for a DEXA scan for more accurate risk assessment. Anyone who's had a low trauma fracture over 50 or any risk of more than 10%. Who to treat? Anybody with a 10-year probability, that is once they've had their DEXA scan, of 20% or more, or 5% for a hip fracture. There are some you may think, well, I really can't send this 89-year-old lady who's got 6 vertebral fractures for a DEXA scan. What's the point? And we accept that. So if it's inappropriate to scan a patient because they've already got 2 or more fragility fractures and they're very elderly, then it may be appropriate just to treat them without a scan. The oral bisphosphonates, generic, cheap, highly effective, with a 74% reduction in further fractures, vertebral fractures in 1 year. Usually dreadfully taken, less than 50% at 1 year take it. But if you can get patients to take it, treat for 5 years, then reassess. Subcutaneous denosumab, 6-monthly injection for those who can't tolerate it, which is a very potent inhibitor of osteoclast activation. And IV zoledronate. Now, IV zoledronate is a very potent bisphosphonate, a 15-minute infusion given annually. Do you expect them to live longer than 6 years because they're very elderly? Or there's difficulties with getting a subcutaneous injection at home. But for the generalist who's not going to be dealing with the parenteral therapies, use the oral bisphosphonates and make sure that you check their compliance. And after 5 years, because this is always a question, how long do you treat for? After 5 years, get a further DEXA scan and reassess their need. And so I'm not going to go on to the how denosumab works for the sake of time, and I'm going to leave you with the slide of osteoporosis made easy. Thank you.
Thank you, Jane. Very interesting. If you have any questions, I would encourage you both to come to the microphone and to give your name and place of work. That is helpful. And while you're thinking of doing that, we have a question from Khartoum. Do we still treat patients with hyperuricemia the same with gout if they don't have gout?
This is a big question, and it's whether you treat asymptomatic hyperuricemia. There is gathering evidence, but not completely definite evidence that a raised serum uric acid is associated with hypertension and increased risk of cardiovascular events. But the latest guidance that came out in 2013 from the 3E group is still that there's insufficient evidence that you should treat asymptomatic hyperuricemia. But I think two years' time we may change that advice, and we need to get more data.
Good. And staying with treatment, Jane, what about the cost of treatment of the parenteral options? This is now thinking about osteoporosis.
Yeah, the oral bisphosphonates in this country, anyway, are incredibly cheap. We're talking about £20 to £24 a year for either alendronate or generic risedronate. Denosumab's £366 annually. IV alendronate, it depends if you use the generic and you have a hospital contract for that, but it's probably about 200, and then the cost of the day unit.
Okay.
So, yeah, ridiculously cheap to treat with oral bisphosphonates, but no point if they don't take them. And don't forget your calcium and vitamin D, particularly in this country, vitamin D.
Thank you. Last question from Tom MacDonald, Dundee.
It's not really a question, it's a remark about your uric acid treatment. We've been doing a large trial in the UK and Denmark of febuxostat versus allopurinol. And we've been titrating people's allopurinol up to the ULR standard. And 65% of people achieve ULR target after one titration. And about 30 to 40% of patients are not at target at baseline. So it's definitely achievable to do it. It's easy, and it actually doesn't cause much in the way of problems for the patient. So we're about to publish that.
Good. Look forward to that.
Good. Thank you very much, Jane. Very interesting. Next speaker is Professor Jeremy Hughes. Jeremy trained in London, and then by way of Nottingham and Seattle, took up a Wellcome Trust Senior Clinical Fellow job in Edinburgh and has segged seamlessly into Professor of Experimental Nephrology and Honorary Clinical Nephrologist here in Edinburgh with a particular interest in inflammation and scarring. Jeremy, you're going to tell us what we need to know about renal medicine.
Okay. Well, I'd like to thank the committee for asking me to speak here, and I'd like to welcome the global audience, which is really fantastic. I'm going to talk about acute kidney injury, and that is because that is the thing which is really exercising the minds of nephrologists and certainly people who work in acute medicine at the moment. I'm going to tell you why, well, what it is, why it's important. I'm going to tell you some of the old things so we can really understand what is new, and that is the NCPOD findings of 2009, which looked at a number of cases of fatal AKI. And then how are we doing and what can we do better, and what the future holds, which I think there is some promise there. So what is it? Well, we don't normally biopsy people who have acute kidney injury because it's a clinical diagnosis and hopefully they'll get better. They don't have acute inflammation. But here you can see a normal kidney with glomeruli and tightly packed tubules all look healthy. And in AKI, we normally see this in transplant patients who have delayed graft function. You can see damage to the tubular cells with cast formation. But again, I emphasize we rarely biopsy these people. They manage clinically in general. I'm not going to go through this, but the pathogenesis is complicated. And there are lots of people actually working in labs around the world with mice models, rat models, human cells in culture. And it involves a variety of things: ischemia, hypoxia, inflammation, sepsis, cytokines. But thus far, despite all this work, we don't really have any novel treatments for AKI. But I hope that's going to change in the future. And one thing which is now becoming important is the fact that we know that regeneration can occur in the kidney, more so in younger people than older people. And that can occur when the insult is going on. So there's a yin-yang, ongoing insult and an attempt to repair. And I think we might be able to augment this in the future, although that is some way off. It's helpful to think of AKI as a spectrum. There will be some patients who are normal, then there are patients who fall into this category where they're at increased risk because of either comorbidities or their infections or whatever. And they evolve into damage, which eventually will declare itself with loss of our eventually kidney failure. And we don't have a great amount of your kidney function. I'm not really going to discuss urine biomarkers. It's a big area, it's somewhat confusing, and I think there's not a clear message there for people who work at the front door or in the community. Now AKI, sorry? Oh.
We're just contacting the projectionist to see what's happening.
Right, I do apologise.
It was an interesting experience. We don't listen particularly carefully.
Did you understand anything of what I said? Shall I wait?
I'll see if I can.
Yeah. It worked in rehearsal. Is that, right, let me go. Okay, so we are working. So I'm just going to show you so you see it. A normal kidney and a healthy kidney from a transplant patient, because we don't normally biopsy native kidneys. This is the complicated pathogenesis, and I'm not going to deal with that, but I think we will get novel therapies from this in the future, but I think it's several years ahead. And this is the idea of insidious development, moving from one stage from being at risk to getting damaged to having impaired function and eventually going into kidney failure. And patients move along this pathway with not much changing in the way of biomarkers until they have significant inflammation and injury. And this is how we can define AKI. Again, it's been difficult. Until recently, there were 44 definitions of acute kidney injury in the literature, which was no good to anybody. But now if you have an increase in serum creatinine by more than 26.5 micromoles per litre in 48 hours, that is AKI stage 1A. If it goes up by more than 1.5-fold from a baseline creatinine, and many patients do have a baseline creatinine in the system, or you can calculate one from the MDRD equation. In the last 7 days, they have AKI. And again, oliguria is important, but more difficult actually to measure in practice, but it is there as a criteria. We have a staging system to try and give people a handle on the severity of the problem. So stage 1 is a relatively minor increase in the creatinine, or from 1.5 to 2-fold. Stage 2, when things are getting more serious, the creatinine's up by 2 to 3-fold, and stage 3 it's up over 3-fold, or you get a hike to more than 354, or they're on dialysis. But these are stages that are helpful, and people are now talking about stage 1A, where you get more of a minor change in creatinine, and stage 1B, where you get a more significant change in creatinine. And there are also output criteria, and they're well, it's common. Different studies show how common it is, but 7% of inpatients may have AKI, and it's got adverse consequences. Many studies have shown that people stay in hospital longer, they have increased morbidity, and they have increased mortality both in hospital and in the community after discharge, and it costs a lot of money. In the UK in 2009-10, about £500 million, which is an awful lot of money. We've done some work looking at cardiac patients in the Royal Infirmary having bypass surgery or valve replacements, and you can see here, this is just some data. If people do not have AKI, they pretty much sail through. Limited mortality, they're out in 10 days. Any AKI, as you get more severe, the mortality goes up significantly, and they stay in hospital for a long time. So this just shows you in different specialities it will have an impact. Not only are there impacts for patient morbidity, mortality, kidney function. So if you have severe AKI, you may be left with CKD, and there are big epidemiology studies from California using Kaiser Permanente data sets that show this is a real risk for patients, and there's an increased risk of going on to develop end-stage renal disease by dialysis. Just a couple of cases that are in my clinic, just to show you the variation. This is a young woman who had big surgery for congenital heart disease over in Glasgow. She came to me after she'd been discharged with a high creatinine. She's done very well. And that is a take-home message. Young people often do very well, and they can recover to very good renal function. And that's part of their capacity to repair and regenerate. This is a 47-year-old lady who has CKD. She's got reflux with a smallish right kidney, but a normal left kidney. And she had a valve replacement with dialysis and intensive care, ARDS. She's had a major loss of her kidney function now. She's got CKD stage 4, and I've no doubt that she will require dialysis in the future. She will slowly drift up at some stage. This is a chap who is otherwise perfectly well, just on an ACE inhibitor for hypertension, but he got the flu. He kept taking his medicine and he felt feel more brutal, and he poisoned himself. He's got a significant loss. Over half his renal function is gone. 46-year-old lady with diabetes. Again, these came through the front door with bad cellulitis, who was bacteremic, and again, severe renal failure. And you can see you actually don't get back to your baseline. And it's hard to see this when you look at a graph of numbers on a user interface in a hospital. The graphs really show you just how much they've lost. Urinary sepsis, very common, a 74-year-old lady. Again, some improvement, but really she's got significant CKD. This is a patient of mine who's got diabetes. She's in socially challenging circumstances. Her control is not great. She's got a stoma for ulcerative colitis, and she's had acute renal failure with profound losses of fluid from diarrhea and vomiting, and she also had a necrotizing fasciitis. And this patient, actually, she's not an ACE inhibitor, but even though she's proteinuric, she's high risk for bouts of AKI, and she's therefore not an inhibitor, which against the grain in a diabetic with proteinuria. They're all straightforward: volume, sepsis, drugs, aging, etc. But you've got to stay alert. So I was on call for the weekend, and this is a patient who was referred to me, a 73-year-old female, admitted with lower limb weakness and a febrile illness, who had Staph aureus on her blood cultures, was found to have an epidural abscess, drained surgically, and they cultured an alpha hemolytic strep from the abscess fluid. Scans normal, echoes normal, no endocarditis, and she's on benzalpen and rifampicin, and she will be on that treatment for a long time. And they're concerned about her kidney function. And that's what her kidney function is doing, it's just going off inexorably. And if I plotted her CRP would be coming down, and she's clinically settling from their point of view. And she's got proteinuria and microscopic hematuria on dipstick. Now, in this circumstance, this is not a simple AKI, because the differential diagnosis here is she may have a post-infectious nephritis from the staph or the strep, or she may have a drug relatus, and she requires long duration of therapy. So she needs a renal biopsy to delineate the cause. So you have to stay alert. And this is where liaisons. From those vignettes, you can see the risk factors: CKD, age, drugs. There's actually a paper out recently showing that if you look at the incidence of AKI and the number of prescriptions of ACE inhibitors and ARB in the UK, they go together, and that some of the AKI may be because we have more patients on these drugs. You've heard about non-steroidals, the key, and then patients who have cardiac disease and other drugs. And then sepsis. There's often occult sepsis playing a role here. Patients who have vascular paths, heart failure, diabetes and liver disease. All these are risk factors for patients developing acute kidney injury. So what were the findings of the NC pod into patients who died with acute kidney injury? Well, they raised a number of issues. A large number of patients were looked at. Only half of them got what they would call good care. Risk factors poorly assessed, omissions in some simple things, delayed diagnosis, and there was a number that were predictable, and that means that if you can get this right, you can actually improve outcome for a large number of patients, save bed occupancy, and save money. Complications were missed. There was delayed referral to the renal service, inadequate early reviews by senior clinicians, escalation of care was inadequate at times, and there were some issues with getting a scan within 24 hours or out of hours at weekends, and also having renal on-site or off-site. But there were issues. Now, because of that, there have been guidelines developed. So we have one from the Renal Association, KDIGO, and also NICE have got guidelines from August of this year, and they can be helpful. What do they tell us? Well, in general, crystalloids are preferred for volume expansion unless someone's bleeding, and vasopressors to maintain blood pressure, etc. There's no role for diuretics in the prevention or treatment of AKI unless you're trying to get rid of salt and water. There have been studies, often small studies, with dopamine, phenoldiazepam, atrial natriuretic peptide, IGF-1. There's no good evidence that these actually work. N-acetylcysteine is not of use in post-surgical or critically unwell patients with AKI. And again, if you're going to give drugs, try and give drugs that are not nephrotoxic. You can use normograms now for giving gentamicin, and you should monitor levels. But we still see patients who have higher levels of potentially toxic drugs, often antibiotics. Contrast is a big thing. People are concerned about patients who have risk factors who go for imaging. But we all know that sick patients need the best imaging, and you need that for patient care. But if you are going to undertake scans in patients that involve contrast, assess the risk and use really the optimal imaging. Sometimes an MRI might be better than a contrast CT scan. And you use the minimal dose of isosmolar contrast. There's now a recommendation that people should be well hydrated, and that ideally is the IV route, but there's some data that you can actually do it by mouth, but recommendation is for IV, and it's isotonic saline or bicarbonate. No real difference between the two. And there's a suggestion from guidelines that you could consider giving N-acetylcysteine before and after the examination to try and limit any nephrotoxic effect. Again, no other drugs really are recommended. So there are some suggestions and guidelines out there for patients, and we see contrast-induced AKI. Often it'll take a few days to evolve, and often it can leave people with residual damage. So in view of all that, how are we doing now? And can we do better? Well, this is a nice study from Sean Finley and Mike Jones and others looking at the incidence and risk factors for AKI in acute medical admissions in the UK, 10 hospitals in England and Scotland. Data was taken over 2 separate 24-hour periods, and AKI was common. 17% of patients roughly had AKI on admission, and in the major analysis, these factors are key: hypovolemia, sepsis, CKD, and diabetes. So again, those common things that we see a lot of. The problem was that the simple things weren't being done. Patients did not have a fluid balance chart. Some of them were on medications that should have been stopped. Some of them did not get the IV fluid they should have received. And some of them did not get a check on the renal function to see if things are getting better, remaining stable, or getting worse. So what can we do? Well, try and do the simple things well. That's often something I tell the juniors in the ward. I actually educate all my patients now if they're on an ACE inhibitor or an ALB or diuretic, if they become unwell with diarrhea, vomiting, dehydration, they can stop that medication and they can pick it up when they're well. And that also goes in their letter as a recommended action for them to take note of. There's issues for junior staff: education, induction, training. Seniors need to review patients early because that can certainly help with ensuring adequate management. And then simple tests, checking the blood tests again, dipping the urine to make sure do they have an active urine with blood and proteinuria, and getting a simple scan if indicated. And again, observations, if we're going to do them, we should try and do them accurately. So urine output, a fluid balance chart, and then various track and trigger systems to make sure that we escalate care accordingly. Stopping drugs, that's something I hammer on to all the undergraduates about. Look at the drug card and stop nephrotoxins, and give IV fluids after you've carefully examined the patient. There's a feel now that we might be giving too much fluid to some patients, and that can be detrimental. And then screen for and treat sepsis. Consider appropriate other tests. So if someone's had a long lie, you might want to do a creatinine kinase or rhabdomyolysis. If someone's got other systemic symptoms, think about vasculitis, because they do occur and they can sit people up. And then really discuss care and escalate accordingly. Now, what do we have for the future? Well, I think technology is going to be one of the big things here, and there's some good work going on in Derby from Nick Selby, Chris McDye and colleagues about electronic alert reporting systems. What they did was a study whereby they were able to use a baseline creatinine or a calculated creatinine, and they were able to highlight on the IT system whether somebody had stage 1 AKI, stage 2 or stage 3 according to the rising creatinine. Now with that system, that means you can track at any time how much AKI you have in your hospital, and they found that 5.4% of admissions had acute kidney injury. And you can track outcome, and again there's a high mortality in association with AKI. And what they also did was they linked the alert to educational material on the internet. So you can actually get the alert that creatinine has gone up with AKI, and you can link directly to things like review medication, assess hydration, monitor urine output, check another UNE. So you get that built in to help people actually manage them on the ward. It also tells you where in the hospital it's occurring, and this is just showing you here. This is renal medicine, this is gastroenterology, general medicine, general surgery, cardiology, and healthcare for the elderly. So you can see the healthcare for the elderly have a lot of acute kidney injury to deal with because of age, comorbidities, and drugs. But these systems give you real power to actually to understand what's happening in your hospital and how you are doing with it, and it can raise the profile of patients with AKI early rather than late. Now, this is a little bit of science. There's been some wonderful work done by Professor Bruce Molitoris in Indiana, and he's spent a long time studying experimental disease where he injects either high molecular weight red dye that will stay in the circulation. You can see here, this is a living rat kidney. The red dye stays in the capillary network, and he'll inject a low molecular weight green dye that will be filtered by the kidney and will go into the urine. You can see here, initially it's in the blood, and then eventually you lose it and it appears in the tubules and then disappears. And you can use the ratio of those two readouts to track real-time GFR. This just shows it in a living rat model. Then he must have had a eureka moment, because he said, why can't we do this in patients in real time in the blood? So now what he's got a portable device, which is a fibre optic device, which sits in the vasculature, and they can actually inject either a high molecular weight red dye that will stay in the blood, or a green dye that will be filtered, and they can track in real time what happens. And you see the red dye stays constant, and the green dye gets filtered, and from the ratio, you can work out filtration. And this is actually data from, it's either a dog or a pig, but the idea is that you can actually get a device which can give you real-time GFR at the point of care. So this is a normal dog. This is a dog with CKD, and you can see the curves are different with reduced filtration in the animal. So what they're aiming for is to be able to have a device that can sit in someone's arm, or possibly through a central line, and if they're high risk of AKI, they can be monitored in high dependency or ITU or post-transplant, and it'll give us real-time data on GFR and also plasma volume. And I think that's something that might help us manage a small cohort of patients in the future. Any questions? Thank you.